Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the areas of advanced illnesses, typically those that would involve either palliative care or hospice care. Those are two separate types of services. I'm also a certified end-of-life doula, an avid writer having published well over 500 healthcare articles, an avid book author and self-publisher having published 21 books for hospice nurses, 24 for caregivers, 5 for holistic nurses, 6 for my fellow end-of-life doulas, and I'm currently working on a brand new series for Christian practitioners who want to incorporate their faith 24/7 in what they do. That book being how to integrate grief from a Christian perspective. We don't get over it, don't move on from it, that we could actually integrate grief, loss, traumatic events into our lives in our walk with Christ Jesus and live a more fulfilled life. If you're new to this channel, welcome. Thank you so much for taking the time to visit. In this channel, we talk about issues related to death and dying and the journey there. After all, we are all going to die. Wouldn't it be better if we understood what that journey looked like? I'll have videos for my fellow hospice nurses. That's going to be the topic for today's video. Videos for my fellow holistic practitioners. I view myself as an holistic nurse. Videos for caregivers, patients, family members, as well as other end-of-life practitioners who are often end-of-life doulas. If these are topics of interest, please consider hitting the subscribe button and then bell notification below. I try to publish videos every Monday, Wednesday, and Friday, corresponding to written articles that are being published on compassioncrossing.info. Occasionally, there'll be a gardening update or a house project update thrown in there as well. If these are topics of interest to you, also consider hitting the like button below. It does help spread the information out there to others. These videos are for educational, entertainment, information purposes. Now, before I go on to the topic of today's video, which is an ongoing discussion, the last video that you watched, unless things get changed up, I had talked about how a doctor from a different hospice agency asked me, how do you help nurses to prognose, to know where somebody's at and get into the visit planning? So I dealt more with the prognosis side of the fence. Now I'd like to get to the second part of that, dealing with hospice nurses, visit planning, time management, just to give some advice from that perspective. And before I go on to that topic, I want to ask you, what are you grateful for? What are you grateful for? So I'm about to write chapter 15. I'm looking right now at a potential 34 chapters. It might be more, it might be slightly less by the time the book's ready for publication for this new book on helping people recover from grief from the perspective of integration versus get over it and move on. And chapter 15 is dealing with gratitude. Chapter 14, which I just finished this morning, is dealing with forgiveness. I believe both of them are extremely important. We talk about building resilience. There are 3 pillars. Forgiveness, yes, is one of them. Gratitude is a major component. I find that if you build resilience, which is an habitual thing you need to be in a habit of, every day, several times a day as you're able, to ask, what are you grateful for? I'm grateful for you. Even if I was here in a blink of an eye, this is not for me, at least to stop by. Thank you. I'm thankful for everyone who buys and reads my books. That helps not only pay the bills, but it helps me operate Compassion Crossing LLC on a sliding scale, where I do a lot for free, mostly helping people in crisis. They're coming to me in crisis and they don't know who to turn to. And I don't know about you, but for me, that's the hardest time to talk dollars and cents. I know I'm valuable. I know I'm offering value, but they're already down on the ground. I don't want to add more weight to them. And maybe some of you might say, well, they're taking advantage of you. Well, in that part, then I'm forgiving and I'm giving them my service, but you allow me to do that by buying books. And I know some of you might, we're enablers. That's its own discussion. And I'm thankful for my wife, Laura, who has been with me through various journeys in life. I am autistic, high functioning. Um, that's not always Rain Man and good things. That's panic attacks and anxiety attacks and other things that I'm not proud of that I go through. And she's been with me through thick and thin. So moving on to the topic of today's video, um, I normally don't, this is not a script, I normally don't do bullet points, but for time's sake, I'm trying to do that for this video. So we're going to be talking about the reality of scheduling. We're going to be talking about some time management. These are going to be very, very tight discussions. Why it is so important as nurses, especially the registered nurses in hospice, we need to be comfortable prognosing. It is within our scope of practice to be able to tell a patient when it's not always a fit to tell the patient. If they're in emotional distress, that may not be the time to tell them their prognosis, or they're not cognitively able to handle the information. But regardless of whether we're telling the patient, the caregiver, or family member, and especially at IDG, we need interdisciplinary group team meetings. We need to be able to discuss based on clinical judgment where we believe that patient is at in their journey in hospice. I strongly believe that. So talking about scheduling, I have to admit that from the scheduling foundation, those of us who are case managers that are out there, whether you're doing this part-time PRN or full-time as I did, there's going to be two main categories, and then you're going to have your PRN visits. So the two main categories, you're going to have agencies, like I remember working at a Care Hospice of York, PA. They were initially, when I first started with them, they were owned by Golden Living, and then later on by Medicis. Both of the owners of Care are good companies. Care had a method of practice that is common in the United States. That's why I want to discuss two methods of scheduling. At Care, they believed in the practice that the clinical manager, who could be the director of nursing, was going to do the routine visit scheduling for you. So on our tablet, we used Home Care Home Base, and it doesn't matter what software you use, but in this case, it was Home Care Home Base. I would, here's your schedule for the week. And then I'd get up in the morning and the clinical manager might have made changes to the schedule from day to day. They believe that it was in the best interest for me and other case managers if they did the scheduling for us. They operated under the belief system that they knew the map in the territory and knew where the other nurses were at. And so sometimes I was seeing patients from other nurses. They were not my patients per se. And so they believed they were in a better position to do that versus to self-scheduling. And they do have, there are some benefits to that. There are some benefits to that because the responsibility for the RN supervisor visits for the CNA was on them, not me. I had to do the supervisor visit, but they took care of the entire hassle of the routine scheduling visits. It is a hassle from a point of view. Then there's the other companies like Grain Hospice that was owned by Abode Health, and then Bright Spring Health Services. And this is back in 2024 and prior. So this is 2025 as I'm filming. Things may have changed. But from Grain Hospice as well as Lifesong Hospice, they were at Harrisburg, but I had York for my territory, York County, Pennsylvania. They were of the philosophy that we, the nurses, should do our own scheduling of everything. And I did like that better for the most part, but it did get interesting remembering to do the LPN because we had Lifesong, we did have LPNs, which was very helpful, by the way. But I had to remember when to do the supervisory visit for the LPNs. I had to remember to do the supervisory visits for the CNA. So I came up with a spreadsheet to keep track of that. And if you watch any, let me just adjust my screen, got the camera involved with the edge. But if you watch any of the Amity Group videos, Shelley Henry does an amazing job at educational videos. She'll go in, that if you're doing your supervisory visits, LPN, CNA, don't do all of them like at 8 o'clock in the morning, one right after the other, because on an audit, you didn't really do them. That would be a different video, by the way. But you have your schedule for you, or you're scheduling your own. And then you have the PRN visits. And for all three agencies, AseraCare Hospice of York, Grain Hospice of York, Lysong Hospice of Harrisburg, I had York Territory, you'd also get calls, whether it be from team members or from the office. So-and-so is having a crisis, go out and see them. One of the benefits for the self-scheduling is I still remember to this day, and I learned a lot at AseraCare. So when I go over the pros and the cons, I am not bashing. If I lived in Pennsylvania, which I don't, and they'd say, Peter, would you like to come back? I would, for all from all but Lifesong. That's its own story, because I doubt that they changed a practice that is very harmful for employees. I won't go further. If you want to ask, email me. Uh, and I would be judicious in what I share, because I don't need problems. But anyway, the catch with the AseraCare with the schedule visits is they schedule them and they'd expect you to complete each and every one. So unless you had a serious, the practitioner, had an extremely serious emergency, you were expected to complete them. And so when they gave you these additional visits, their standard was 6 visits a day. Some days would be 5, 6 visits a day. Now, if they gave you an admission, they drop you down to 3 or 4 routine, sometimes 2 if you were really blessed. And I don't know how to word that. I felt, because the last video I went in the importance of interviewing. So I interview when I do admissions. I really dig in deep. And then I'm having discussions with the medical director of every single medication, PRN, and routine, doing a genuine medication reconciliation, not just checking the boxes. So the catch is that when they called you for these PRN visits, if you had 6 on your schedule and you had 3 PRN visits, now you're doing 9. And if you're a nurse like me, where the average visit time for a rural home patient was an hour and 15 minutes to an hour and a half, you can do the math. That doesn't include travel time. You can do the math. So the plus side with Grain Hospice and Lifesong, since you did your own scheduling, is I would communicate to the different parties, what, I had a change of condition for one of my patients. Could I see you tomorrow or the day after that? Like, I can move people around. And it's not that I could not with AseraCare. They just made it a little bit more complicated with their rules and regulations. You had to have a very thick skin, which I did towards the end, in terms of fighting for that right to, do the communication. Like, I check with the family, please, this is doable. And by the way, my fellow nurses, get a thick skin, advocate for yourself. Even at Grain Hospice, I had cases where one of my coworkers, the one who'd it would be common for her to do 18 to 20-minute visits and brag about it. Like, the longest I ever spent in a patient's home was 45 minutes because the wife made me. It's like, oh, my brain's exploding. It still does now from a point of view. It's like, or you were complaining because you were spending time with the patient and family and caregivers. In hospice, they're dying. But I still remember the case where I was asked to see 3 additional patients, and I went with my, to my manager. Okay, I'll see those patients. In fact, after the visit I'm in now, I'll go there next, because one of them was a critical change of condition, and that was the right thing to do no matter what. But I said, uh, these other patients I'm not going to be able to see today, or could the after hours person see them? So part of what I do want to discuss when you're looking at that is I do have a book out there. This is particularly written for rural hospice nurses. So if you're an inpatient hospice nurse, this has some tips, but the majority of this is for the rural hospice nurse. This talks about proper use of technology, looking at like getting your GPS, Google Maps at the beginning of the week. I would be, where does everybody live? And I'd literally create a map, and I'd use Google Maps to help. Where is this person from me? From me to home, where does this person live? And I'd literally like the toothpicks and the rubber bands, or the little pins and the rubber bands, where do they live in relationship to one another? No, I'm not kidding you. This was, in a way, like a crime map, but they weren't criminals, to be very clear. But the reason that I did that is, especially when you could self-schedule, I want to group these. These are my high acuity patients. These are my low acuity patients. This is where they live in relation to one another. This is where I'm going to start my day based on where I live in relation to them and their acuity level. This is where I'm going to end my day, so on and so forth. So this book goes over a lot of tidbits that you're not going to get anywhere else. And it is a rather thick, it's one of my thicker books, especially this benefits you, especially if you're making your own schedules. But even if you're not, it gives you a point of how to advocate. Like, I shouldn't say it doesn't tell you how to advocate for yourself, but you can come up, you can actually, if you feel comfortable, hey, I've done my own schedule for the week. Could we talk? And be careful, like if they're giving you patients that are for other nurses, there's a reason why they're doing that. Think of your team members. This is not all about you. Remember, Jesus, others, you, and I'm not trying to preach to you. But you do want to be a team player. So you do want to look at, if you're going to move anybody, maybe it's your patients that you move around. Do try to be careful with that. But getting back into the doctor who asked the question, like, how do you learn? And I did share with them part of the catch is, um, even if I were to say, buy all 20 of my books, to remember the 21st is to help get people to be a hospice nurse. So 20 books are about the practice, empowering you for excellence in practice. Even if you get all 20 books, which I would appreciate, the issue is that's not going to turn you into an expert overnight. You have to put it into practice. I still remember Tara Marie, she's now Tara Marie Pandoli, unless something changed. She was Tara Marie Stein when I first met her. She's director of nursing at Sarah Care Hospice of York. Uh, excellent mentor, excellent mentor, excellent hospice nurse. And um, I still remember her, with oh, this is the perfect schedule for you. And it's like, this is 45 minutes from here to there. Like I would start towards the end when I got more comfortable in my own skin, so to speak. Yeah, I can map this out better, no offense. Could we move these around? They'll still get the same the same number of visits per week, but this would actually be better, and you can get that way. And so that's something that you learn by putting into practice. I still remember Tara Marie Pandoli when Dr. Eric Barr, he's a wonderful medical director, was talking about the benefits of dexamethasone and the differences between dexamethasone and prednisone when you're talking about maintenance medications versus acute events, prednisone acute, dexamethasone maintenance. And Peter, you were the only hospice nurse who immediately put into practice when to use dexamethasone and using it effectively, and also following up to see that it's used effectively, and watching for the main side effect for us hospice nurses to watch for is that Cushing-like syndrome, the face puffing up. And it may not just be the face. I've had patients where it's the wrist, hand, wrist swelling, ankle swelling, and so on, where you have to catch it and nip it in the bud, so to speak. But she would be the one you immediately made it into a habit. And that's why I ask you about, like, what are you grateful for? Make it a habit. So when you learn about these different things, my books and other sources, put into practice what you're learning, and then it becomes a habit, and then you do better at it. But I did direct a doctor to this book here. This book and this book go very much hand in hand. Time managed for hospice nurse, hospice visit planning. Anytime that you have a change of condition, anytime this just gets into the prognosis part, the art of hospice prognosis. If I know that they have 2 weeks to live, me personally, I'm going to try to see them daily. And this, by the way, every hospice agency is going to have their gold standard for what to do in the last 2 weeks of life. Sarah Care Hospice was daily visits. Grain Hospice was only daily visits if they're actively dying. And that's something, by the way, that I bucked against for several reasons, because when you look at the Medicare benefit for how many visits that they get within the last 72 hours before their last breath, we don't know how long somebody's going to actively die. Active dying could be seconds. I still remember my patient that was actively dying. I put them on daily visits at Sarah Care Hospice of December 23rd, 2018, and I pronounced them January 9th, 2019. I was seeing them daily. And I'm the type, I'm a weirdo. Yes, I'm autistic. I'm a weirdo. I asked to work every weekend for certain cases, even if I wasn't scheduled to, because I wanted to be the nurse to see it to the end for certain cases. And I couldn't have told you it was going to last that long. And if you waited till they were actively dying, now in that case, you wait till they're actively dying, yes, you would have got on all the visits to get the Medicare extra money, so to speak. But I've had cases where they're actively dying and they started on one evening, they're active dying, they're dead the next. Didn't know. But if you start seeing them in their last 2 weeks before they active die, you're going to not only get all those visits in, you're going to get those medications stopped sooner. You're going to help the family, the caregiver, especially the caregiver. You're going to help everyone along the way. You're going to improve your satisfaction scores through the roof going that route. And then Lifelong Hospice was a very mixed bag for that. And again, this is just how it was. But by knowing the prognosis, if I have somebody that I strongly believe, my gut feeling is they're 6 months or less, and especially if I'm questioning that you're gonna pass their first recertification. If they get a common cold, I'm gonna just exaggerate for a degree. If they get a common cold, I'm probably gonna do telephone tuck-ins. If they are at the month or less mark, and yes, you can get to the point where you know that they have hours. I'm not saying we are ever God, but you can get to the point where I know they have hours. I know they have hours. They have a common cold. I'm putting in a PRN visit. If one's not scheduled for the next day, I'm coming back the next day. I'm letting the team know. I'm going to choose my words so that my own words, my body language, my volume, and my inflection does not minimize. It's just a cold. I want to make sure that everybody's on high alert that this might be more than what it seems. And the hard part, and I did share this with the doctor on LinkedIn, this is something that you learn by doing. You learn by doing. And over the years, I've had clinical managers go, Peter, I don't understand you. Your schedule tomorrow is super booked, and yet you're putting in another visit. And some the better ones would actually ask me if I need help, and I would ask for help if they did that. Other managers would not offer help, and I still would put in the extra visit, and I would pray that there would be help along the way. And you could argue, if you have a thick skin, you'll ask for help. And there were cases where it was like, I have 10. I was asking for help. And some would say, Peter, you did it to yourself. You have to do this. Or take off the PRN visit. And I knew in my heart the right thing was to do is to see that person. This is hard. There's a lot of burnout among hospice nurses. That's why we need the better clinical managers. Peter, let me see what visits can take off. And this is, by the way, to give Lifesong some credit, this is why any hospice agency that has those LPNs That's where I can go to Katie, or I think it was Angela. I don't have memorized all the different LPNs that I worked with. You know what? I need to see, like, I still remember the week of that ended June 14th, that Friday, where I was let go for advocating from, I don't know if it was advocating for my lung cancer patient who wanted powder sedation, or because back in May I answered the family. Here's what Dr. Patrick 𝐂𝐒𝐿 told me, a local York doctor, on certain injectable products that are not safe and effective, or ageism. But I still remember that week where I was seeing that patient every day, because there was emotional distress, there was hallucinations, there was a lot of other things going on, and I'd call Angela, do you mind seeing so and so? Katie, do you mind seeing so and so? And that's some of the benefits when you do have a strong team like that. Or at times, just calling up people that operated in the same geographic area. Hey, do you have a full schedule today? If not, if they do, I'm just checking in. Thank you. And by the way, offer to be of help to them. This is team. This is team. But we're out there to support one another. That's part of why I'm doing these videos, just to try to help you with different ideas, to encourage you. Even if you're not buying my books, there's a lot of on compassioncrossing.info. I have a lot of free articles. Doesn't have the word teach prognosis in them, but if you go to how much longer is dealing with prognosing, that entire section of articles deals with prognosis. Uh, on March 27th, if you're in South Carolina, I'm going to be one of the 3 keynote speakers, the only hospice nurse that they've had in a while, if ever. And I'm going to be talking about prognosing. So if they have the opportunity to go, I don't know if there's going to be a door charge to that, by the way. But I'll put in the link in the description below, these particular books. But if you're a rural hospice nurse, these are secrets that I've learned over the years. Art of Hospice Visit Planning, yes, is a thinner book, but this just goes into building your nursing gut on, I need to put in that PRN visit. And by the way, not everything is I need to see them the next day. Sometimes you have to look at everything. And this is, again, the prognosis, the primary terminal diagnosis, the comorbidities, not just alphabetically, just what's going to kill them fastest if things go their normal course. And they're unrelated, they could actually contribute and make things worse. By knowing all of that, sometimes it's, you know what, I'm seeing them on a Monday. I would next see them on a Thursday, or maybe it's just a Monday visit. Let me put in a Thursday visit, or maybe it's a Tuesday visit and that's it. Maybe put in a Friday visit. The more you space it out, in some cases, is better, not only to see if they are recovering from that event that had you thinking, I need to see them another time, or maybe they got worse and now we have to think of doing increasing their routine visits. Now, every place that I've worked, including places that I didn't feel treated me the best, like Lifesong Hospice, June 14th, I got screamed at because I was going through the proper channel. I didn't get screamed at for going through the proper channels, but I waited to the end to say this is a village. I talked to the patient about powder sedation. I talked to the POA, their daughter. I talked to the nursing staff, who was telling me the moment I got in the door, she's asking to be knocked out until she dies. That's powder sedation. I talked to the director of nursing. So after all, I had all the ducks in a row. I needed to hear back from the owner of the assisted living if they would allow things to go forward. Then I'd call the doctor. Don't call the doctor until you have your ducks in a row. But when I sent out the secure encrypted email, this is a village. I need the chaplain, the social worker. I need everybody involved. If I get the okay, I'm going to initiate powder sedation. I'm going to be the one coming dailies. Yes, I'm coming 7 days a week. I'm going to be doing all that to support the team and the patient and the daughter and so on. Within 30 seconds, a minute of that call, I got a call from Michelle Campbell screaming at, how dare you? And I still remember the livid call. How dare you go that week? And it's Lifesong Hospice and Palliative Care is in the name. How dare I do that? I went too far. You know, we one day we may do palliative sedation, but not today. Blah 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 blah. Come in for 3 o'clock, and I got let go. And Michelle, yes, I forgive you. Um, but even with that, there were things Lifesong Hospice did correctly. There were things that they did correctly. The LPNs helping out is correct. The just, you know, I don't know how to word things, but that was part of the correctness, the ability to move things around in scheduling, the ability to work as a team and say to the different team members, like Denise, who I believe moved on from there for similar reasons, but hers as it was a choice versus mine, and which wasn't. But you know, we would call up and say, you know, do you need help over in this territory, over in that territory, and be a part of the solution for this. If you have any questions, please comment below. I thank you for watching this. Take care. God bless. And